ID Masterclass, which is from the Clinical Infectious Disease Society Post-Graduation PG Subcommittee. We're very happy to have you all, especially on a busy weekday. And we really understand that all of you are very enthusiastic to listen to a very, very important topic, which is antimicrobial stewardship, which is actually the need of the hour. Glad to have you all here. Just a quick announcement. Please keep your audios and your mic and your videos in mute. We apologize for the previous technical glitch that we had on our last meeting. I'm sure this will get better over the days, over the meetings to come. I will hand over the mic now to Dr. Neha Mishra.
So good evening, everyone. Thank you, Dr. Vidya. Nitin, can you stop sharing so I can share Madam's introduction slide? So just a second. So yeah. Good evening, everybody. I'm Dr. Neha Mishra. I'm consultant infectious disease at Manipal Hospital, Bangalore. I welcome you all to this third ID Masterclass organized by SIDS PG Education Subcommittee. It's an effort by SIDS to increase awareness regarding infectious diseases and sensitize the younger doctors, regarding the subject. It provides them to learn from the best regarding the subject. And today we are going to talk about very, very important topic, that is antimicrobial stewardship. It's an honor to introduce today's speaker, Dr. Priscilla Rupali Madam. She's a great teacher. She's my mentor, and I have done my training under her. Apart from that, she has a lot of degrees to her this thing. So she has done her fellowship in infectious disease from Auckland City Hospital, and she has done her diploma in tropical medicine and hygiene from Peru. She has also done her formal training in infectious diseases from Detroit, Michigan. She runs a very famous clinical tropical medicine course, which runs on yearly basis at CMC Vellore. She also has started fellowship in general ID, which is to train secondary and tertiary care centers. And she also collaborates with MSF and initiates a global health humanitarian medicine program for LMICs. She has started fellowship in AMS for pharmacists. She is also one of the founder member of Transplant ID conferences. She has authored and co-authored several papers, and she's very eminent researcher as well. So it's, without taking much of a time, I would, I would hand over the session to Priscilla Madam. Madam, over to you. We all are keen on hearing next. So I'll stop sharing my slides, and I'll request everybody to kindly mute themselves so that there's less disturbance during the session. Thank you.
Okay, so good evening, everyone. And thank you, Neha, for that really long introduction. It's a pleasure to be here. And as you can gather, for the many courses, teaching is one of my passions. And most of the work that I do actually centers around training people in various aspects. So antimicrobial stewardship is something that is not often, unfortunately, taught to all of us in undergraduates, as postgraduates. And I still remember the horror when I was doing my general medicine, when one of my professors said, hey, you don't know what to do with this antibiotic. Why don't we ask the hematologist, because they use all these antibiotics. I remember at that time, as a final year postgraduate, I said, okay, I'm going to do infectious diseases because this is ridiculous. Why should I ask a hematologist? All right, so let's go on quickly. And now, very quick slide on how antimicrobial resistance emerges. This is susceptible bacteria. They can have point mutations, and you can get resistant bacteria with chromosomal mutations. Or you can have plasmids, which are sitting in there, those nice extracellular the DNA, which are nice circles there, they can transfer and the bacteria become resistant. Then what happens is, in any colony of bacteria which is contributing to a particular infection, you will always have one or two organisms in whatever the whole colony that is producing that infection. One of them will already have resistance elements in it. That is usually the norm. And what happens with antimicrobial exposure is that resistant state, the wild types actually die out, the nice susceptible ones die out, and the resistance ones then go on to predominate. And that is what actually contributes to majority of the resistant infections. So these bacteria will become prominent in our gut, in the various microbiomes, whether it's respiratory, whether it's gut, and then they go on again to spread infections, not just for that particular patient as well, but then can go on to be spread in a hospital environment from one patient to another. So bacteria not only transmit resistance elements to each other, but they transmit it to humans as well. And that's the reason why we're here. So you can see here, the burden is high. Yeah, MRSA, we are maybe not as bad as some countries, but still it's 50 to 60%. Klebsiella, carbapenem resistant Klebsiella pneumonia, which is like the bane of our existence right now. That again is 50 to 60%. Most of our E. coli are now extended spectrum beta-lactamase producing, almost 70 to 80%, whereas blood cultures, and so on and so forth. And this is the carbapenem resistant Acinetobacter baumannii. There you can see how India is actually quite high on the resistance pattern. So what I'm going to be talking about is actually taken from a set number of resource materials. There are plenty of them around, believe me. This is one very good one by Dr. Dilip Nathwani. If you just Google him, he's been one of the doyens of antimicrobial stewardship from the very beginning. He's written numerous books, numerous pocket guides, and he's a WHO consultant for stewardship as well. This is the WHO toolkit that we also actually helped develop. And you can see here, it's actually very good for implementation in the lower middle income country settings. IDSA and SHE have also come up with how to implement an antimicrobial stewardship program in tertiary care centers. So you will actually have plenty of these resource materials. Even ICMR on its website has antimicrobial stewardship booklet that is available, which is actually quite useful as well. So what really does an AMSP team comprise of? So it's usually a physician leader with some infectious disease training. It can be co-led with a pharmacist leader who has some definite ID training. All the prescribers who prescribe antibiotics, they are key to actually contributing to the success of a program. So clinicians and heads of department. You can also have hospital epidemiologists who can monitor, who can analyze and report facility-wide data to check what the trends are. Quality management staff usually apply management principles to be able to bring it about, and they contribute to a lot to the NABH accreditation and quality improvement programs. You have microbiology laboratories who have which contribute to antibiograms to guide empiric therapy. Then you have the IT staff who can actually help you integrate stewardship protocols into an existing workflow. And these AI things are coming into big way right now. Nurses can ensure that cultures are taken before starting antibiotics. So these are the key components. You have to have a leadership commitment. Without a leadership commitment, really, it cannot happen. Accountability, some drug expertise. You have to have a multidisciplinary approach. You have to introduce policies in a prioritized way. Then you have to measure what is going on. So I've done this. Now I have to measure it and see whether it's working, and then report and provide ongoing education. So the way to make it a success is to explain to everyone around you that it's actually a patient safety priority. I think that's that's a key word to use. Until we use that word, usually no administrator will actually accept it. We have to make the management accountable. We have to have a multi-professional AMS team with a strong, influential clinical leader. That's a very important thing. Becomes very difficult otherwise to communicate with other members of the clinical teams. Whatever you implement has to have an evidence base, and you have to be able to show it to them that it's making a difference. Constantly educate and innovate. It may seem like it isn't working initially, but as the times change, even now I can see compared to what it was 10 years ago in my hospital compared to what it is now, there's a distinct difference between the way people actually look at antibiotics and use it. Whatever short-term wins are there, always consolidate them and then go on to implement them. So now let's go on to antimicrobial stewardship. These are coordinated interventions which are designed to improve and measure the appropriate use of antibiotics. How do you do it? You select it appropriately. You give the correct dose, you give it for the correct duration, make sure the route of administration is correct. At the end of it, we want to make sure that our patient is all right and there are no adverse events that are noted, trying to decrease the Clostridium difficile infections, and of course, antimicrobial resistance rates. Why, I don't need to tell you. Obviously, we are the resistance hub of the world. Very few antibiotics, especially gram-negatives. It's been a very disappointing pipeline. WHO also has recognized antimicrobial resistance as one of its top 3 threats to human health. And generally, we know that 1/3 of the antimicrobial use in acute care settings among humans is actually inappropriate. So while we can't control what's happening in poultry or apiculture or aquaculture or in animal husbandry, we can definitely control what happens and what is under our control. So what are the principles of antimicrobial stewardship? And I think the most important step is that we have to make a diagnosis and we have to use multiple data points to come to a diagnosis. So not just one thing, you have to treat the patients. You don't just look at blood tests and decide to give antibiotics. You send confirmatory tests based on what the diagnosis you've made. So very, very important. So Siddharth Mukherjee, who wrote his Laws of Medicine, and there he has a very good phrase there. Strong intuition is better than a weak test. So it's very important for us to use our clinical knowledge to be able to come to a diagnosis. Then limit empiric antibiotic therapy to life-threatening situations. And there are very few of them. There are about 6 or 7 life-threatening situations where we don't really wait for the cultures or any such thing to actually start antibiotics. We have to know the local antibiotic resistance patterns, know the correct dose, correct choice, the route of antibiotics. PK/PD parameters of the antibiotic prescribed are very, very important for us, for the clinician to be aware of, especially the one who's prescribing. De-escalate once diagnosis is obtained. You have a confirmatory diagnosis and you have a susceptibility, just go ahead and de-escalate. So this is, I'm sure, something that everybody would have seen and heard. So you start smart. So you start depending on what you think the likely diagnosis is, what are the pathogens, what is the susceptibility, and then you review. So you start smart and then you focus after 48 hours. So you check the microbiology reports and then you decide, okay, do I want to stop? Do I want to switch? Do I want to change to a narrow spectrum agent, which is technically de-escalation? Or do I want to continue because I'm not really sure and I feel that this antibiotic is probably required? Review after 4 hours and go on to outpatient antibiotic therapy. So define clinical situations where antibiotics can be stopped. And these are the few situations. All the viral infections that you encounter commonly in clinical practice: pharyngitis, rhinosinusitis, bronchitis, non-infectious cardiopulmonary disorders, some acute otitis media. Very few of them are really suppurative. Some skin and soft tissue infections, selected ones like small abscesses or stasis dermatitis or asymptomatic bacteriuria, colonizers, and any kind of low-grade fevers. What is the duration of antimicrobial therapy for each particular instance? Now, there's increasing evidence that shorter is actually definitely the better, and there are definite defined durations for whatever infection that you're attempting to treat. So acquired pneumonia, healthcare pneumonia, skin and soft tissue infections, urinary tract, Staph aureus bacteremia, which we really respect. So you can see that's the one which is in weeks, intra-abdominal infections, and of course, surgical prophylaxis. So I like these golden rules. This is Mind Me. This is from Dr. Natwani's book. Microbiology guides therapy wherever possible. Indications should be evidence-based. Choose the narrowest spectrum that you can possibly choose. Make sure the dosage is appropriate to the site and the type of infection. You minimize the duration of therapy and ensure monotherapy in most cases. I'll just quickly go on to the strategies. There are various strategies that can be used to improve antibiotic use. You have certain persuasive strategies where you say, okay, please, can you reduce it? You give education, you create guidelines, you remind them, and then you provide audit and feedback, but you really don't cut it off. You allow them to actually do it. The restrictive one is where you're saying no right from the beginning. So you restrict it from the formulary itself. You just don't stock it. Then you have compulsory order forms where they have to actually, have it on an order form where they have to order it to actually be able to obtain it. They have to have expert approval to get it. and of course, automatic stop orders, which can happen in a system, in an electronic medical record system. So these are called as core ASP strategies. Front end is your formulary restriction and pre-authorization. Back end is where you do a prospective audit and feedback. So basically, somebody has been on antibiotics for 48 hours. You go back after 48 hours, find a patient is still on, and then you actually have a dialogue with the clinician, depending on what you think the diagnosis is. And you have the microbiology data also available in 48 hours. That helps you to timely de-escalate antibiotics and to reduction in appropriate use. So just very quickly, this is just a gentleman who has abdominal pain, vomiting, and high-grade fever. He has tender guarding and rigidity, so he's an acute abdomen. The treating physician says he's got meropenem. So when you look at pre-authorization versus prospective audit and feedback, how does it work? Now, pre-authorization means the moment he writes meropenem, it actually has to be approved by an ID consultant or an ID registrar or somebody before he can it's actually dispensed from the pharmacy. Prospective audit and feedback is a little more conciliatory. Basically, they can prescribe it, but 48 hours later, you go back and look and check and ask them, okay, have you done a source removal? Have you got pus results back, culture results back? Okay, does it show something where you can actually step down therapy? So that is called as a prospective audit and feedback. So really, there are a lot of advantages and disadvantages. Pre-authorization reduces empiric initiation of inappropriate antibiotics. Very often, it reduces costs as well. It encourages frequent and early review of culture data. Disadvantages is sometimes delays therapy, and the prescriber feels very uneasy because he's lost autonomy. And basically, it only impacts certain agents which you have actually put under the gambit of pre-authorization. Prospective audit is basically, it actually brings your whole ASP program into light. So people actually respect it because there is increased visibility, there's more data, uptake is better. It's a collaborative effort between the ASP team and the clinician, and the prescriber autonomy is still maintained because they still feel that they can go ahead and they can cut off the antibiotics. Of course, it's very labor intensive. Compliance is actually voluntary, and sometimes there can be a prescriber reluctance to change. We have other things, didactic education, activities like we're having now, but it cannot be a sole means of reducing inappropriate antibiotic use. You can have facility-specific clinical guidelines, which is an effective way to kind of standardize prescribing practices. And that can be based on local epidemiology. So it's really contextualized and people can actually use it. You can also have, teams which go around, stopping orders, encouraging routine reviews of prescriptions. So it can happen with a team who goes around and asks the physician, why is it that this is still on board? But it actually requires a lot of prompting, and it still is a weak recommendation with very low quality evidence. You can also have a computerized system where its opportunities are integrated into the electronic health record, and that can actually identify various opportunities for interventions. You can also have antibiograms. So all of us have antibiograms in our institution, and we have an antibiogram which looks like this. But when you actually, the microbiology laboratory reports the susceptibility, they can do what is a cascade reporting. So let's say an organism is susceptible to the first-line antibiotics. They won't release a report for the other antibiotics. So that's called as a cascade reporting. So antibiograms, both stratified, non-stratified, and cascade reporting, all of these are lab-based diagnostic stewardship methodologies which can also be used. So among all these, where is the evidence that it works? So the ones which have an asterisk next to them are the ones which have been proven by evidence. So formulary restriction, pre-authorization, prospective audit and feedback, multidisciplinary stewardship team, timely de-escalation, dose optimization, parenteral to oral conversion, and guidelines and clinical pathways. These are shown to be evidence-based of reducing antibiotic consumption and improving stewardship. Okay, so I've kind of finished the theory part of it. Now comes the interactive part of the whole session, and you guys have to be attentive and please put up your things in the chat box, and Neha will actually tell me what the majority of you think. Okay, so the idea is for you to identify the opportunities for antibiotic stewardship in all these cases. Let's assume it's me, the doctor, who's given certain antibiotics, and you have to tell me how terrible I am with regard to this. So this is a 75-year-old male, diabetic, 7-day history of swelling, lower limb, pain, bulle, pus discharge. He also has an NSTEMI during admission with mild respiratory distress. He shifted to the ICU, requires intubation. He undergoes a debridement and a plantar fasciotomy on the day of admission. These are his vitals. You can see here the vitals are actually pretty good. He does have a slight leukocytosis there, but otherwise everything is okay. You can see that he has a little bit, his troponin T is elevated, so maybe there is something going on in the muscle. The chest X-ray is showing perihilar opacities. This is his microbiology. So cultures, urine is no growth, blood no growth, sputum is no growth. This is superficial pus swab that has shown MRSA, Pseudomonas, and Streptococcus. So obviously what he has, the diagnosis is not in doubt, is a necrotizing skin and soft tissue infection, okay, probably a necrotizing fasciitis, possibly even muscular involvement. So maybe there is a myositis as well because the trop T is high. So he started on this piperacillin tazobactam and clindamycin. Piperacillin tazobactam is given for 8 days, clindamycin is given for 5 days. But generally, he's been afebrile since the 3rd day, CRP and procalcitonin come down remarkably. And then the patient is subsequently changed to linezolid and azithromycin. Okay, so what is the likely causative organism here? Now you have actually a pus swab showing you an MRSA, Pseudomonas, and Streptococcus. So which of these is likely to be the most likely diagnosis here, most likely organism? Let's see if anything is up there on the chat. Neha, you can tell me. So Streptococcus, some people say Streptococcus, excellent. So Streptococcus is by far the most common. Streptococcus pyogenes and Staph aureus is the next most common. You're right, polymicrobial infections can occur, and usually they do occur in the elderly and those who have diabetes and probably immunosuppressed. Pseudomonas is less likely to be the organism, but you can see here the empiric choice was piperacillin tazobactam and clindamycin. So identify the stewardship intervention opportunities here. So what is wrong about the prescription that you actually saw here, and where are the opportunities? Okay, sorry, where are the opportunities? Do I have anything on the chat? Okay, let's go on to this. And then I want you to actually tell me what you think is wrong. You're absolutely right. Streptococcus pyogenes is the most likely one. Staphylococcus aureus is the second most common. And you have these other organisms which can cause it. Okay. All right. So I'm just looking at it. Linezolid is not necessary. De-escalation from linezolid. Excellent. So we have some very excellent physicians in this audience here. So you're absolutely right. The first thing that you notice is piperacillin tazobactam and clindamycin was probably an appropriate choice. We want clindamycin for toxin mop-up. Now, did he really need piperacillin tazobactam for 8 days? And do they really need linezolid and azithromycin for 5 days? So you can see here, you look at this, I call this guy my AMS lens. Okay, and so with the AMS lens, you can see that if a person is afebrile by the 3rd day, really they don't need intravenous antibiotics, and you can change to an oral antibiotic. Patient is subsequently changed to linezolid and azithromycin. And you can see here, that is where the problem is. Azithromycin is useless, absolutely. You don't really need linezolid as well. So yes, this is a necrotizing skin and soft tissue infection, and you really don't need antibiotics more than 7 to 10 days. And these 2 steps are absolutely unnecessary. Okay. Excellent. So yes, shorter is better, and whichever infection that you're looking at, it is becoming shorter and shorter by the day. So this is the step 4 trial for intra-abdominal infections, and you can see here definitely shorter regimens are found to be efficacious. They compare 10 versus 4 days after adequate source control, but of course adequate source control is actually key here. Satya, could you just mute all the participants, please? There was no difference in the 2 groups with regard to skin and soft tissue infections, recurrent intra-abdominal infections, and death. Same thing with VAP. Again, 15 days versus 8 days. There is enough data to say shorter durations work much better. And there is even a Cochrane database of systematic reviews which shows this. This is a more recent one where for acute pyelonephritis and septic urinary tract infections, definitely favors a short treatment, whatever outcome was actually chosen. Right, so shorten duration of antibiotic therapy wherever possible, because remember, an antibiotic will change your gut flora, and whatever gut flora you've changed, that change is likely to last for a minimum of, anybody knows, 6 months. So it's likely to change, to remain changed for at least 6 months, and in some cases, it's found to be as long as a year. So you're actually predisposing that person to antibiotic-resistant infections if he is unlucky enough to have one in the future. Let's go on to the next one. This is a 45-year-old male with analgesic abuse for osteoarthritis, abdominal pain, duodenal ulcer perforation. Started on meropenem, gentamicin, and flagyl. And you can see here, patient was actually sick to begin with, rigid abdomen here. And blood culture had shown no growth, but a pus that they sent from theater showed an ESBL E. coli, which was sensitive to piperacillin tazobactam. And chest x-ray had shown an opacity. He undergoes an emergency laparotomy or mental patch repair, shifted to the ICU. So was the empirical therapy here appropriate? Yes, no. Is de-escalation possible now that the culture results are available? You've got to quickly answer in your chat box. Okay, it was not appropriate. Somebody said yes, yes. No need for flagyl and genta, mero and flagyl dual. Excellent. Okay, great. So absolutely, you're absolutely right. That's where the AMS lens comes in. Really, you don't need gentamicin and flagyl. Meropenem covers all the gastrointestinal anaerobes, and you don't really need additional gentamicin and flagyl. Now, what about the, so this is ESBL E. coli, which is sensitive to piperacillin tazobactam. Do you want to actually de-escalate? Do you want to de-escalate? Yes, no? Quickly, everyone. So that's where my next flag is. Mero single sufficient. So no, yes, yes. So a lot of people want to actually de-escalate here. Okay, all right. I would have agreed with you. So same thing, avoid redundant double coverage. So gram-negative and anaerobic. You don't need additional gram-negative or anaerobic covers because it covers most gram-positives, gram-negatives, and anaerobes. Now let's come to my second question that I talked about, de-escalation. Now, we've all heard about this inoculum effect, right? So when you take a serious infection, you're expecting that the microbial load is high. And when they checked out what is called as this inoculum effect, what they really found, so if you just pay attention to any one of them, so let's say SHV2, you can see here as the inoculum went up, okay, 10 to the power 7, can you see how the MIC went up dramatically? So something that is likely to be susceptible at 10 to the power 5 has actually dramatically increased to 256. Now, this is supposed to be an in vitro lab phenomenon. Does it really work in vivo? Should we really bother about it in vivo? So yes, there's been a lot of debate back and forth, and and you can see here there have been studies which have been done have shown that actually when there is a higher inoculum as expected in probably somebody with severe sepsis syndrome, whether it's bacteremia, septic shock, or a severe sepsis like this where the patient actually had a rigid abdomen, it is better to actually go ahead and give carbapenem therapy as it has a mortality benefit over piperacillin tazobactam. So, I mean, I appreciate the thought that we have to de-escalate to a narrower spectrum of antibiotics, but it's important to remember we have to keep the patient's outcomes in mind as well. All right, third one, 44-year-old banker, hospital for suture removal. She was operated for umbilical hernia last week. She has a short-term Foley's catheterization, no known comorbidities, and you can see here she was actually quite all right. And the intern, you can see here her test, intern ordered some tests, and the urine routine has 14 cells, ultrasound is normal, and the urine has shown this. So the person is panicking now and is starting treatment with meropenem for 10 days. So is the treatment choice here appropriate? What do people think? Appropriate, inappropriate? Answers on the chat, please. Okay, no symptoms, no treatment. Absolutely, totally agree. So how do you differentiate between a colonizer and a true pathogen? Now, first of all, the question is, why did this intern actually send? He was trying to be thorough, but actually mucked up. So you can see here how to differentiate between a colonizer and a true pathogen. Very important thing. Yes, there are many GNB that are there here, but there are two organisms, and this second organism is not seen in the culture. You can see here the urine routine actually doesn't show any WBCs at all. Patient is asymptomatic. Urine routine doesn't match the urine culture and the colony count. So despite the fact that this colony count seems dramatically high, really this is a colonizer, does not really need treatment. So don't treat colonizers and contaminants. Excellent. So bacteriuria, not a disease. Very few instances where you will treat it. Pregnant woman and a person undergoing a urethral, basically some kind of a procedure where you have to go via the urethra. But the most important thing to remember is a midstream clean catch urine does not actually decrease the bacterial contamination. And that's very, very important to actually remember. When you have a single organism it is in the correct clinical picture, then yes, take it into consideration, but always correlate clinical. Okay, so definitely these are the flags. Patient did not need any treatment and this was totally unnecessary. Urine routine did not match the urine culture. All right, slightly more difficult. 28-year-old lady, a subcutaneous panniculitis, T-cell lymphoma. She's given CHOP E here. She presents on 14th of, this is a case from a while ago, fever, cough with expectoration and loose stools. Some odynophagia and ENT actually rules out actually peritonsillar abscess. There's no history of breathlessness, oliguria, or hematuria. Okay. And the vitals, you can see her blood pressure is 76/40, her pulse rate is high, she's icteric, she's pale, she's some erythema that is seen on the medial aspect of the thigh. And she's in ICU for observation. She requires inotropes and oxygen by mask. Her neutrophil count is actually just 100 cells, so she's really ill. And her platelets are also low. Her hemoglobin is also low, so she's got a pancytopenia. Creatinine is all right, but she was put into ICU. She was started on meropenem initially, then she was escalated to colistin in about 5 hours or so. The qualitative PCR for influenza comes back as positive for influenza B. All right. So what would you do next? She's febrile neutropenia. Just to recap, febrile neutropenia for 6 days. She's in septic shock. She has a clinical and a microbiologically documented infection. This is her blood culture. Okay. Now, remember, she's on meropenem and colistin. Okay. And would you de-escalate? And if so, to what and why? And is it safe to de-escalate in this hypotensive neutropenic patient? Okay, so let's see what the answers are. Would you de-escalate? We've had answers like no, so meropenem, colistin to continue. Nobody wants to de-escalate. Somebody is saying yes, yay. Okay, so what do you want to de-escalate to? Piptaz, fabulous. Okay, continue meropenem alone. Somebody says yes. Okay, is it safe to de-escalate in this hypotensive neutropenic patient? So yes, we seem to have a lot of people who want to de-escalate, and they say that it is actually safe. We've also had cefperazone, sulbactam. Colistin with meropenem does work, but do you really need to give colistin? That's the point here. All right, so let's look at it. So look at this. You're absolutely right. This is E. coli. This is an E. coli which is pan-susceptible. And you can see here piperacillin tazobactam is susceptible. Cefperazone sulbactam is susceptible. Actually, any antibiotic here is susceptible. But there is a catch here. And for those who said cefperazone sulbactam, the catch here is this patient is still neutropenic. And this patient came with a septic shock. So whatever you do in a neutropenic patient, you want to maintain pseudomonal cover. So if you take off colistin, you're on the right track. If you maintain meropenem, you're still good. Or if you want to step down to piperacillin tazobactam, you're still okay. If you have a situation where your fluoroquinolones are susceptible, you'd still be okay with fluoroquinolones. But here, the Cipro was resistant, so nobody really thought of that. So the question was, is it safe to de-escalate in this hypotensive neutropenic patient? So a lot of people want to de-escalate. Somebody wants to add posaconazole. Well, this is a short term. This is not a patient who has been consistently neutropenic. This is not a patient who is after a bone marrow transplant. This patient has not received one of those chemotherapy regimens which makes them neutropenic for a long time. But if you suspect that the patient has had an invasive fungal infection in the past, then definitely you will think in terms of posaconazole. All right, let's go on. So yes, de-escalation of empiric therapy is associated with lower mortality in severe sepsis and septic shock. So for those of you who have to argue with your intensivist, where they tell you, see, look, this treatment is the one which worked, it's very important to be able to tell them that de-escalation is actually protective, and it actually has a mortality benefit as well. So de-escalation definitely is required. But I think this is my last case. This is a 57-year-old man, fever and dry cough for 3 days, diabetic, hypertensive, hypothyroid with chronic kidney disease on stage 5 hemodialysis. And you can see here his hemoglobin is low, platelets are low, his creatinine is really high, blood cultures are negative, he's rapidly worsened, he's on a ventilator, and he started on meropenem. So what is the differential diagnosis for this patient with this particular chest X-ray? So what is the first, what is the diagnosis here? So any takers to what it could be? Could be a VAP, okay, all right. He's not been in ICU for more than 3 days, but yeah, he's beyond the 48 hours cutoff. Leptospirosis, okay, all right. Community acquired pneumonia, okay. Streptococcus pneumoniae, fungal infection, okay. COVID, okay, I love that answer. Exclude heart failure, absolutely. So I think that's a very important point. Remember, he has a kidney failure, so heart failure, I'm glad people are coming up with that. So it's very important to be able to figure out what is the likely diagnosis here. So pulmonary edema, yes, it is likely to be pulmonary edema because the creatinine is actually pretty high. This patient has all the risk factors for possibly a heart failure, so it could be a heart failure. But more than that, fever, cough with an interstitial pattern, it could definitely be a viral pneumonia, so COVID should be a very important thing to actually consider. A TOF could be tracheoesophageal fistula or tetralogy of Fallot. Well, he's an old elderly gentleman. Now, what do you want to do actually with this patient? The patient is on meropenem now. Now, what do you want to do next? You want to make sure that this meropenem needs to be given. So what is the things that you can do to confirm these diagnoses? And what is the stewardship opportunity? What will you use for a stewardship opportunity here? You want to do a BAL? Okay, yeah, absolutely. BAL can be done. Film-array pneumonia panel, presumably on the BAL. Okay, yeah, that's fine. Respiratory panel PCR, yes, absolutely. You want to do a ProCal? Excellent. All right, so yes, this is a difficult patient because you don't really know what's happening. Patient is sick on a ventilator, is an obvious chest X-ray opacity, so you're quite right. And all of you have actually given us the right thing. His influenza PCR comes back as positive. Okay, so then what do you want to do? Once the influenza PCR is positive, pneumoslide IgM, I must say I've not heard of that. Latex agglutination, yes, but not pneumoslide. Gram stain and cultures, yes, absolutely, I totally agree with you. Now that you know influenza is positive, what do you want to do next? This is influenza PCR only. You want to stop antibiotic cover? Absolutely. You want to stop the meropenem. You want to isolate, okay, because of influenza. Okay, fine. You want to add teicoplanin and de-escalate. Cover anaerobic, change to piptaz. Okay, we've got a wide variety of answers here. So it's just to recapitulate how difficult sometimes it can be in an intensive care setting. So there are a few clues that we can use, and all of you have given these options here. We know that this is likely to be an influenza. In addition, probably there is a renal failure contributing to it. It is possible he also has an underlying left ventricular failure because of all the risk factors that he has. The chances that this is a bacterial infection is lower because the history seems more suggestive of a viral at the moment. It's too early to think in terms of a secondary infection as a result of the influenza pneumonia. So I would actually think in terms of doing something else to make sure that I can take off the meropenem. So what are the things that I can use? Oops. What are the things that I can use here? Yes, I would actually go ahead and do a polymerase chain assay, to do PCRs. We know that any adults who've had nasopharyngeal swabs collected and have a rapid result, you can actually find that appropriate antibiotics can actually be de-escalated. Antibiotics can be de-escalated or discontinued or stopped when you're using rapid diagnostic techniques. So I think wherever you have access to rapid diagnostic techniques, please go ahead and order it. So this is the aspect of diagnostic stewardship, and any rapid diagnostic point of care test can actually reduce antibiotic use. So once you have a influenza result positive, you can safely go ahead and de-escalate or discontinue actually the meropenem, because this is likely to be probably multifactorial, probably contributed to influenza and possibly some pulmonary edema as well. So procalcitonin, yes, that also has been shown to actually reduce initiation, the duration of antibiotics, and the total exposure to antibiotics per se. Okay, so I'm already at 8:43. So just very quickly summing up, there are plenty of AMS metrics that you can use in your hospital. And these are the various metrics that you can use. Your pharmacist will be very aware of it. So you can use daily defined doses, days of therapy, length of therapy. You can use patient-related outcome. You can use the resistance patterns coming down, but that takes ages to come down. You can use prescriber metrics, that is drug utilization by prescribers, percentage of order of antimicrobials, etc. This is what we do in our hospital. So we have like a DOT per 100 patients days that we monitor. And these are the various antibiotics that we look at. So we've chosen a few that we want to keep an eye on. So I actually have a question here. Many centers do not have PCR facilities. What to do in those settings? Dr. Pandey, I would actually go with my clinical judgment. So just saying that your clinical judgment is what we need to go by, because we know that this patient likely has multifactorial reasons for chest X-ray picture requiring intubation and ventilation. So I think in these situations, we have to be bold and stop the antibiotics, because the chances that he will get something like an Acinetobacter baumannii, which is resistant to meropenem, is much, much higher at a later date, because he's going to be in the ICU for possibly ages. So antibiotics are definitely not harmless, and they can wipe out all the good bacteria in the gut, leaving the multi-resistant bacteria to proliferate. In addition, we can transmit to the community in the other hospitals. These MDR genes can be transferred to other bacteria as well. So that actually perpetuates this resistance cycle. And of course, it increases hospital costs. So we're going to have the largest burden of AMR by 2050. And I think we're going to be in a huge problem here. I think Asia and Africa are going to contribute to the most of the deaths by 2050. So I'm just going to sum up here. So this is my picture for low-hanging fruits. So if you see the fruits hanging there, what can you easily do? And what we can easily do is make a clinical diagnosis. We can send appropriate lab tests to confirm a diagnosis. We have to be aware of the local susceptibility pattern. We have to know what the PK/PD of the antibiotic is that has been prescribed. Be bold about de-escalating, discontinuing, or modifying once culture results are available. Treat urgently only in certain situations. Now, these are the situations: so shock, necrotizing fasciitis, bacterial meningitis, community-acquired pneumonia, ventilator-associated pneumonia, febrile neutropenia. There are very few conditions where the mortality is pretty high if you don't treat urgently. The rest of them, you can actually wait to get a culture, or, at least even if you start antibiotics, make sure that you have some means of going back down. So what should you not do? Don't give antibiotics for just a fever. Make a diagnosis so that you're committed to it. And it doesn't matter if you're wrong. You can always revise it 48 hours later. Try not to treat colonizers or contaminants. You have to be bold and say, no, I don't want to treat it. Don't give it for longer duration than necessary, because even reducing a duration of 5 days is going to make a remarkable difference to that patient's particular gut microbiome or respiratory microbiome. Don't give antibiotics without checking if it will work at the site of infections. And you're all aware there are certain antibiotics which don't work in certain sites, whether it's daptomycin in lung or echinocandins in urine. There are certain areas where it will not actually work. And don't assume that failure is always failure to respond is always because of drug resistance. There may be some other reason. We actually had a young boy who had MRSA, community acquired, and multiple abscesses everywhere. And he had an MRSA for which we had given vancomycin, but his GFR was extremely high, and we were not really dosing him adequately because we were just giving him 1 gram Q12 batch. So once we did a vancomycin assay, we knew that we were actually underdosing him, and we had to give him massive doses of about 4 grams a day because he actually had a GFR of something like 600 ml per minute. So these are all the few things that you have to actually do to be able to think about what is actually happening in a particular patient. So thank you for your patient listening. I think I'm going to stop with this. And yes, please have a look at this WHO's manual. It's really pretty good. I'll hand back over to you.
Thank you so much, ma'am. That's one very beautiful lecture, and I'm sure everybody has understood and got some clarity about what is antimicrobial stewardship. So we'll now carry out some question and answers. People who have any questions or queries may post their questions into the chat box. So I'll see if there are any questions so far. So there's somebody who's asking, Madam, gram-stain-based initial antibiotic therapy, utility in AMS. So
yes, gram-stain can be pretty useful. It depends on where you're taking it from. If it's from a sterile site, a gram-stain can definitely give you direction as to what to start. So if you have a single, let's say you pneumonia and you have a sputum which is likely to actually be something. If you find in a CSF, you have to be a little more wary because there can be a higher MIC for organisms with streptococcal pneumonia, meningitis. So gram-stain can definitely be very, very useful. Does Piptas cover Enterococcus? Sorry, I saw the last question. Yes, it does cover Enterococcus very well, but meropenem does not cover. That's a very important point to note. So piperacillin has one advantage over meropenem with regard to coverage of Enterococcus.
Use of pneumonia plus panels and treatment strategies.
Well, I really don't find pneumonia panels very useful, to be frank. I think their utility and their cost effectiveness has not been demonstrated. So I feel that clinical judgment still is the best. You can use simple tests like gram-stain to give you the first of diagnosis. Yes, once you are sure that it's likely to be a viral syndrome, then yes, you can go in for a panel which can cover respiratory virus PCRs, which can give you a little bit of direction with regard to start of Tamiflu, especially if the patient is really, really ill.
Rati is asking, what is the role of microbiologist in AMSP apart from drafting cumulative antibiograms? Why is it still broadly considered by clinicians that microbiologists should be restricted to labs?
I think it's a very simple answer here, because the clinicians are the ones who prescribe antibiotics. Microbiologist is very much a part of the team. Clinician cannot work, AMSP will not work without the microbiologist. I think it's a very, very important thing to remember. So unless the microbiologist is able to come up with an antibiogram, there is no point the clinician implementing an antibiotic stewardship program. So one cannot coexist without the other. Both work there is a lot of complementarity there. And once you have an antibiogram, you can actually, the clinician who's a prescriber will be able to actually dialogue with other prescribers, and they will be more willing to listen, because a lot of the AMSP is actually dependent on your clinical diagnosis. And It takes a lot of courage to go to the bedside of a febrile neutropenia patient who's in septic shock, and you examine them and you find a lot of little clues here and there to be able to tell the clinician to actually stop it. I think you need a clinician for AMSP, but a microbiologist is very, very important, has an extremely important role to play as well.
Quite a bit of questions. One more question is ceftazidime, avibactam, and aztreonam in drug-resistant GNB, especially non-fermenters. Any guidelines? Okay.
Well, that's a tough one. So ceftazidime, avibactam in gram-negative organisms, it definitely has a niche. As you know, our carbapenem-resistant Klebsiella pneumoniae, what used to be NDM earlier is now from NDM, it moved to NDM plus OXA. And now you're actually seeing far more OXA than you're seeing NDMs. There are situations, of course, when we see both as well, but OXA is predominant. And so in that situation, you can actually go ahead with just ceftazidime, avibactam if you're sure that OXA group is what is contributing to the resistance here. I hope I've been able to answer that. But otherwise, it's dicey. I totally agree. To be able to prescribe ceftazidime, avibactam alone, you really need sequencing to be able to tell you whether it is OXA or not. In today's world, if you want to cover everything, then yes, you may want to use ceftazidime, avibactam plus aztreonam. If you find that the local antibiogram says that you have more OXAs versus NDMs, and if you want to be, especially in a febrile neutropenia patient, if you want to cover all bases, you can start with that and then de-escalate once you have results available.
I mean, any reason? Okay. Empirical antibiotic of choice in septic arthritis.
Okay. All right. So septic arthritis, it depends. There are a variety of reasons why you can have a septic arthritis. The commonest reason is actually Streptococcus pyogenes, and the second most common reason can be Staphylococcus aureus. When you're considering a septic arthritis, I think you have to take the context here and see whether the patient is coming from the community or whether the patient has been in hospital for a while. And if the patient has been in hospital for a while, then you would like to cover it broader. So in that case, I would probably think in terms of the Piperacillin tazobactam, if it's a hospital-acquired septic arthritis. Still, I actually have confirmatory results available because you can never really predict what the patient is likely to have. If it's community-acquired, I would be comfortable with starting something that covers both staph and strep. If I'm worried about if the person has risk factors for MRSA, then I would probably go in with vancomycin and then de-escalate to cloxacillin or cefazolin, depending on what is actually available in that particular hospital.
So, Dr. Neha, thank you so much. Actually, sorry that I have to interrupt, but it's been a really wonderful session and very, very interesting. And we have an excellent interactive audience. But I'm sure there is a bit for the, at least about 10 minutes time for a few brain teasers. I really thank Dr. Priscilla immensely for having spent her valuable evening and time here, this was a really great academic feast. And Dr. Neha, would you want to take over for the, the small brain teaser quiz session also? I'm sure a lot of it is going to be interesting there as well.
Yes. So first of all, he has stopped sharing. So
while Dr. Neha, puts up her questions, I'm sure all of you, seem to be very interested in this topic, and you have a lot more actually in coming up. We would want you to register for our upcoming conference, Clinical Infectious Disease Society conference. That is the 12th annual conference between the 14th and the 17th of July at Calcutta. Please go on to the www.sidsindia.org website. Please send in your abstracts as well and do your registrations. You're going to have much more there as in infectious diseases.
Yeah.
And Priscilla ma'am, thank you so much. I think now we'll have quiz related to AMS that Dr. Neha is going to share.
Yeah. So Good evening, everybody. This quiz has to be answered by students. I would ask anybody who is not a student to refrain from answering. So quiz questions, question number one, there will be 3 questions. You have to answer all the questions all together and post it in the chat box. So here comes your first question. The question is 25-year-old gentleman who had a history of road traffic accident with traumatic brain injury and subarachnoid hemorrhage. He also had multiple brain contusions and skull fracture. There was a bulb hole drainage done with tracheostomy, and he had 2 ICU admissions, which were not exceeding 72 hours. He then developed high grade of fever and decline in sensorium on day 20 of admission. His blood pressure at the time of fever was 110/70 and pulse rate was 112 per minute. Since there was a decline in sensorium, CSF analysis was done and cultures were sent. At that time, his total count was 17,000 with 90% polymorphs. He was started on cefoperazone, sulbactam, and vancomycin after sending appropriate blood cultures and CSF cultures. CSF culture from both the side had growth of Klebsiella pneumoniae, and the susceptibilities are as follows. You can see the susceptibility in the slide below. So the question is, what antibiotic and at what dosage will you choose in this case? So answer all the 3 questions together. Don't answer them separately, and put it up in the chat box. So, moving on to next question. This is the second question is 32-year-old female with no comorbid condition presented with incidental finding of few discrete small nodular swelling in neck for 10 days. She had no other symptoms. USG neck, which was done, revealed cervical lymphadenopathy at level 2, and largest one was 10 millimeter into 8 millimeter size. The blood work done, including CRP, CBC, liver functions, and kidney function tests, were within normal limits, although they went ahead and did a lymph node core biopsy. So the results revealed the gram stain did not show any pus or bacteria. TB-PCR done at that time was negative. Histopathology revealed reactive lymphadenopathy, and the culture report which was done is as follows. Question is, how will you treat this patient? So moving on to our last question. I again will repeat, please answer them together. Don't message them separately. Answer them in the same message. Third question is, Mrs. W, 55-year-old female, case of metastatic CA colon, post-surgery planned for chemotherapy, presented with fever. Total counts were 21,000 with 90% polymorph. CRP was 201, creatinine was 0.52. She had hypotension, tachycardia, temperature was 101. On evaluation, her blood culture revealed Enterococcus faecium. 3 cultures growing same organism on 12th, 13th March and 17th March. She was initially started on teicoplanin and meropenem. Echocardiography revealed aortic vegetation and susceptibility were as follows. So question is, what are the antibiotic of choice in your case, in this case, and how will you escalate or de-escalate the treatment? So moving on to the answers. I believe everybody has answered. We'll give them 2 minutes. Please answer them together so that we can. Okay, I'm moving on to the answers. So question number 1, Klebsiella isolate that was seen was an ESBL producer. In view of meningeal involvement, carbapenem should be used, which should be used at least in a higher dose. Dosage should be 120 milligrams per kilogram per day, 2 gram Q8H ideally. Second is, the patient is asymptomatic, lymph nodes found were detected incidentally, histopathologically there is no infective etiology seen, gram stain is negative, there's no, therefore the growth seen could be due to probable skin contaminant, no treatment required in this case, close observation is needed. Third answer is Enterococcus faecium isolated with is penicillin sensitive bacilli and in the above mentioned case. There's an evidence of endocarditis as well. Therefore, ampicillin with gentamicin should be the treatment of choice. No evidence of gram-negative organism, hence meropenem can be stopped. Okay. So, okay, that ends. So, Nitin, have you? Fine, I think Akshata or Rahul Garg.
Yeah, I think we have Dr. Akshata,
Rahul and Mr. Tahir.
Dr. Rahul Garg and Dr. Tahira Noor.
So, fine. Yeah. So that brings us to the end of the session. And we thank you so much.
We would also like to, actually the prize winners to type out from where they are, their email ID and their contact, their email addresses and their contact numbers as well.
Yes, please do that so that we are able to send your gift prizes.
We have Dr. Rahul Garg. We have Dr. Rahul Garg, Dr. Akshata, and Dr. Tahira Noor.
Yes. Okay. So I think Dr. Rahul Garg has not posted his name. We request Dr. Rahul Garg to please post his name and his mail ID and number. Either of them is fine. If you don't want to post it, okay, sure. I got his name. So thank you so much for all the participation. It was really a very, very nice session by ma'am. We thank ma'am immensely, and it was pleasure having this interactive session with you. So now we would request everybody to also be a part of SITSCON, which is happening in July, and the details will be shared to you soon. Shared with you soon. So Vidya madam, maybe we'll hand it over to you to give the thank you note. You are muted, ma'am. Vidya madam, you're muted. You're not able to unmute, is it? Okay. I would like to thank everybody on behalf of Vidya madam. And with this, I think I will end the session. Thank you everyone once again for joining.
Kindly do register for the SITSCON. Log on to the SITS site, www.sitsindia.org. You'll have more ID questions and interactions there. I think like Dr. Priscilla said, we would require more sessions here also. Many of them wanted AST interpretations by clinicians, MICs, etc. But I think we are definitely, we made a note of that, and we're going to have them organized subsequently. So just watch out for our SIDS PG subcommittees, these CMEs, which are going to be there every month, maybe the second week of every month is what we've planned. So watch out for them.
Yes. Yeah. I think please be little watchful about the pamphlets that circulate every second week of every month. We'll be holding such sessions very frequently. Thanks everybody. I think we'll be signing out with this. Thank you. Leave.